Good morning, everybody, and you're all very welcome. This is my first meeting as the new chairman, so please be gentle with me. As usual, I've got one or two things to go through. I'm Councillor Liz Harsant, and obviously I shall be chairing the meeting. This meeting is being broadcast live and is available to watch on the Council's website whilst we are in public session. A recording of the meeting will also be available for subsequent viewing. Members of the public and the press may record, film, photograph or broadcast this meeting when the public and press are not lawfully excluded, provided due courtesy and respect are shown to others in attendance in line with the Council's published guidance. We're not expecting a fire drill today. In the event of the alarm sounding, please leave the chamber by following the fire exit signs at the rear of the chamber. Fire evacuation instructions can also be found on page 4 of the agenda. Can I remind you please to speak clearly and directly into the microphones and avoid placing things such as papers or IT equipment in front of the microphone, as this will affect the sound quality on the live broadcast and in the chamber. And finally, can I ask you to turn your mobiles and laptops onto silent if you haven't already done so. So the first item on the agenda, good morning and welcome, is public participation session, and we've had no applications to speak in this session at all. 2, apologies for absence and substitutions. I don't think we've received any apologies. No. I'd just like to say that we still have a vacancy to be filled by West Suffolk, and we haven't heard from them as to who that councillor will be. And Suffolk County Council also have a vacancy. So we're also, although we've tried hard to get someone to come along today, nobody has actually offered, have they, Catherine? Declarations of interest. Are there any declarations of interest in respect of any matters to be considered at this meeting? None? Thank you very much. And then the minutes of the previous meeting, which of course I wasn't here, but I believe Councillor Lockington chaired this. Are you happy for these to be signed and as a correct record? Thank you all very much indeed. And so we come to the important part of the meeting, which is the Norfolk and Suffolk Foundation Trust Improvement Programme, which they're going to give us an update. They offer specialist mental health services for people in Suffolk and Norfolk, and this is obviously provided by the Norfolk and Suffolk NHS Foundation Trust, known as NSFT. I get those so muddled up. NSFT, thank you. NSFT has been through a period of prolonged instability and for some time was in NHS England's Recovery Support Programme, formerly known as Special Measures. The committee has regularly monitored the progress of the Trust over this period. Agenda item 5, which is this one, will enable the committee to hear how the new arrangements with NSFT are being embedded and to receive an update on the Trust's improvement programme and progress on its work with partners to ensure continued improvements of the services available to patients in Suffolk. Welcome. May I call you Kath? I believe you're going to introduce your colleagues, and then I believe you're going to do a presentation for the members. Thank you.
Thank you so much, Chair, and thank you for inviting us to come and give an update to the Health Scrutiny Committee. I'm Kath Byford. I'm the Chief Patient Experience Officer and Deputy Chief Exec. Can I introduce my colleagues?
Hi all, I'm Tom Davis. I'm Chief Delivery Officer.
Good morning everyone, I'm Rebecca Driver, Director of Communications and Engagement at the Trust.
Thank you. So I think colleagues will have received the paper, but we thought it would be helpful to just bring it to life a little bit through a presentation which Tom is going to lead. I think you've got the clicker, Tom, haven't you?
I have.
Thank you. So I think colleagues will have received the paper, but we thought it would be helpful to just bring it to life a little bit through a presentation which Tom is going to lead. I think you've got the clicker, Tom, haven't you?
I have. So I'm just going to briefly take you through the key developments at the Trust since we last presented to HOSC, also covering the 3 questions that you had for us last time, which were relating to the improvement programme, specifically governance and leadership at the Trust. Then I'll work with service users and carers, and also the CQC and developments there. So as you can see in the slide up on screen, in terms of governance, since we last presented to you, we've significantly strengthened our board. So Caroline Donovan, our Chief Executive Officer, became substantive in her role in December 2024, and we've now fully recruited to our executive team on a substantive basis. This is the first time, I think, in the memory of the Trust that we've had a fully substantive executive team. 5 of the team come from CQC outstanding rated organisations, so we're trying to bring in experience and a strength of experience in outstanding practice. We also have a full complement of non-executives supporting Zoe Billingham, our chair. The recent appointment of Oliver Shanley was a particular coup for the Trust. So Oliver chairs our quality committee. He's recognised as an exceptional leader in mental health services nationally, with 30 years experience in mental health, starting as a nurse on a ward. He recently led the external review of Greater Manchester Mental Health Trust, so his experience across the country, and it's a really exciting moment for the Trust. So I think probably the strength of this board level recruitment probably reveals the increased standing that the Trust now has. I think nationally, and this has been part of our successful delivery, certainly of the governance element of our improvement programme. Just moving on, I think another really key element of leadership improvement has been our move to a locality structure that you can see here. So in early 2025, we implemented our locality model across Norfolk and Suffolk. This means that we have localities that are now coterminous with our acute providers across both Norfolk and Suffolk, and aligned to the alliances that are being developed across the counties. So our localities now are building direct relationships with those partners in their own localities, with the intention being to make sure we can tailor our services to the needs of those populations. Each locality delivers a core offer of services, but they also, on behalf of the Trust, host specialist services to make sure we have that balance of a core consistent offer while also delivering some highly specialist services. In terms of leadership, as you can see on the slide, we've got a full complement of leaders leading those localities. Each has a triumvirate leadership model, which is quite a well-established model, with a medical director, a director of nursing, and a director of operations. I think when we presented to you before, we had set our strategic priorities in our improvement programme. Those 4 strategic priorities on the left are what we're trying to deliver, and we deliver them through the programmes on the right that represent our improvement programme itself. We're nearing the end of the 2nd year of delivery of that programme, and this is the mechanism by which we're delivering against our strategy. Most of these programmes themselves are multi-year programmes, representing the challenges that the Trust has been addressing previously and our path to improvement. You'll see here that one of the programmes is specifically focused on service users, carers and families. So I'll talk a bit more about that work in a minute, but it's a key priority for the Trust to better engage with our service users and carers and better support them so that our services shape the needs that they have. One of the programmes, and really the cornerstone of our overall improvement programme, is our clinical transformation work. So this is a multi-year programme led by our Chief Transformation Officer, and it's designed to improve our frontline services. The services you can see on the left here are our 5 kind of core service areas, and that's the focus for now. On the right-hand side of the slide, you can see the aims for the programme, but I think it's, to kind of bring this to life, I think it's really worth kind of calling out that we recognise there's been historically geographical inequity in provision across Norfolk and Suffolk. Part of that is due to commissioning relationships, part of that is the Trust's, the way the Trust has been set up. And through this programme, we're really looking to make sure we're delivering that core, consistent offer for our services, so there isn't a geographical lottery for service users. The programme itself has significant service user and carer engagement, so service users and carers are aligned to each of the programmes individually to help support with direct input into the programmes. If I just move on to CQC, another of the key questions you had. So on the left, you can see the CQC's definition of core services. So there's 11 services that are recognised as core services by the CQC for mental health providers. Roughly speaking, these core services are split by definitions of age, so children's or working age adults or older adults, or by the setting, so whether it's a community or inpatient setting, or whether it's a kind of specialist area for particular conditions such as learning disabilities or autism. As you can see, this is the overall position for our services. The majority of our services are now rated good. We've had 3 assessments this year from the CQC and a couple of good assessments within that. So again, I think that evidences the improvements we've made. Some areas, you'll see here, particularly on the bottom of the list, haven't been assessed for a while, so we're really keen for the CQC to come back this year and see those services. And a couple of those services, when the CQC visited a few years ago now, there was insufficient evidence for them at the time, so we're really keen for them to come back and assess these services and show that improvement. If I just move on to our most recent assessment, just on well-led first. So the CQC also visited us last year to assess our well-led standing. So they assess us. It's a little bit complicated. They've changed their assessment criteria to try and be more specific and granular. They've probably made it slightly more complicated. But they assess all trusts by the quality statements on the left-hand side. And trusts get a rating from 1 to 4, with 4 being outstanding and 1 being inadequate. And then they have a scoring system that builds that picture up based on your scores. We requires improvement. We got an improved score, but still requires improvement. We're now on the cusp of good, so we're really keen for the CQC to return this year because there's a couple of areas where we've made significant improvement. That the narrative kind of supported that improvement, and they'd like to see kind of further evidence of progress over time. So we'd hope they'll come back this year, and then we can evidence that we've moved into good as a well-led organisation. Our most recent assessment was for forensic services. So forensic services are those that work most closely with the Ministry of Justice and Prison Services. We were already rated good for this service, but we had one element that was rated as requires improvement. Our new assessment that came out, we were assessed in October, it came out in December, has us good across the board for all of the areas and all of the subdomains that sit underneath there. There are actually some areas that are rated outstanding as individual areas. So again, I think it's a good pointer to the fact we're improving, and I think it just shows the commitment of our staff base working in these services. The report was really it was a joy to read, really, the relationships that our staff have with our service users in this service and how they support them. In terms of service users and carers specifically, so this is one of our large-scale change programmes. We developed back in summer 2024 a service user and carer strategy, and our programme now has been to deliver that strategy. I think there's a couple of key activities I'd like to call out to you all. So firstly, we established our Service User and Carer Council. That council's been running for about a year now. We're maturing it, working with a co-production partner called Rethink Mental Illness, who are helping us support the council to take its role. We've made an appointment of a co-chair in Roy Marsh, so we've got 2 co-chairs for the council. One, Talia, who's Norfolk-based, and Roy is Suffolk-based. So I think we're trying to make sure we've got that equity across Norfolk and Suffolk. And we've now launched our locality service user and carer councils. So this is the overarching council that's been established for a year, and each of those 5 localities have local councils to support the local population. West Suffolk, this is a really new development. West Suffolk are meeting tomorrow, and East Suffolk are meeting today. So it's the first meetings of those new groups. So we're really excited for them this year. And I think just shows that we're committed to really understanding from those with lived experience and want them to play a key role in the delivery of services and shaping of future services. In October, you may have heard, but in October we launched our co-produced carers charter to really recognise the role that carers play, and often the hidden role that carers play. That charter really emphasises the ways in which we expect all our colleagues across the organisation to work in partnership with carers. And we're now working to make sure that charter is fully disseminated amongst colleagues and part of our learning. On the right of the slide here, you can just see our friends and family test. So this is the key kind of national measure that assesses our engagement with service users, friends and family. As you can see from the numbers, we've improved significantly this score over the past 2 years. Again, it's another good indicator of improvement. I think the work that we're doing now is really to segment this score so we really understand any differences between individual services and can work on that, because I think naturally some services will score more strongly than others, and that will allow us to focus our efforts. In terms of improving our culture, which is one of our key strategic areas, there's 2 other elements I'd just quickly like to brief you on. So our Listening into Action programme is really our model of delivering bottom-up staff-led change throughout the organisation. So really trying to instill a sense of opportunity for staff to instigate change themselves. We've run this programme for 2 waves now over the past 18 months or so, and delivered a number of specific missions, and it was the Carers Charter is one example of a piece of work identified by staff and service users that they've then focused on, and this has been the programme to deliver it. So we're continuing that programme and hope that that becomes our real driver for change, so that our frontline staff feel they can instigate change in a large organisation. And then our final programme in this space is about 18 months ago we commissioned a diagnostic report to understand the racism felt by our black and ethnic minority colleagues in the organisation. From this, we've now developed a strategic plan to try and deliver race equity for all colleagues who are working in the Trust. That programme has just launched in the last couple of months, and is one of the key elements of our improvement work, is to try and really drive race equity so that all our colleagues feel they have fair and equal opportunities in terms of work at NSFT. Just a couple of slides, I promise, but I think this is probably quite an important one. I think this slide really shows the impact of our culture work in terms of our workforce data. So as you can see, we're retaining staff to a much greater level than before. We've got much more interest in terms of recruitment. I think the Trust is seen as a good place to work for colleagues, as evidenced by this data too. We had a couple of pre-meets with Councillor Harsant and Councillor Lockington, and I think you picked up, Councillor Lockington, on the fact that this was a particular challenge for the Trust, and I think this is evidence that we're starting to try and turn that corner because of evidence of our improvement. And then finally onto the money. So improving value is our final strategic priority. Now, the financial challenge for all trusts moving into the next financial year is greater than previous years. That aligns with the public sector more broadly, I know. So we're in a position where finances are getting tighter, but demand is increasing, and we know that demand is increasing for our services for a variety of factors. So we're currently working through our financial submission at the moment with NHS England and with our commissioners, our Integrated Care Board. We know we're going to have to make efficiencies of 5% or more, and we're working through the detail of that now. We are on track to deliver our financial plan for the year, for this financial year, which is a really good sign. But achieving an achievable financial settlement for 26-27 is a real priority for the Trust, so that we can continue our improvement and ensure that mental health is continuing to be funded with greater parity to physical health. That's been a previous challenge for the mental health sector more widely. I think I have to say that our commissioners also recognise this and do want to make sure that mental health is funded and has parity. So we're working towards a sustainable financial plan for 26-27. Currently in the middle of that work, but I think once we get to the later stages, we'll be happy to share the outcome of that work with this group. Councillor Harsant, Chair, that's the update for now. Happy to take questions, of course.
Yes, thank you very much indeed. That was really very helpful, Tom. Kath, do you want to say anything just to finish off before we open it up for questions?
Yeah, thank you. I think I'd just like to wrap this part up by saying, it is really important that we recognise the progress that we've made, but we do not underestimate there continues to be further improvement that's needed. So when we are able to be proud and celebrating the improvements that we've made, much of that is on the back of the staff who deliver our services. They're the people. So when we go, we reflect with pride on our the outcome of our forensic service inspection. Believe me, it was the staff and the feedback from the service users that gave that outcome, not about what people like us told the CQC. So we have to be proud and celebrate the successes, because our staff deserve that and our service users deserve that. Yet there is still more to be done, and the framework of our strategic plan, our strategic priorities and our large-scale change programme that Tom described in the presentation is the real mechanism behind us doing that. So we recognise the improvements, but we also recognise there's continues to be more to do. So thank you so much.
Thank you very much for that. Members, Councillor Robinson.
Thank you, Chair. It's nice to see you all again anyway. When I was first involved in health scrutiny in 2017 onwards, dealing with the NSFT was quite difficult. Their focus was almost totally on management, not on workforce, and they had great trouble recruiting and retaining staff, and the atmosphere was a bit them and us. Now, I'm gratified to see things have improved a great deal, and the figures reflect that. But I've noticed a lot of the things where you require improvement are still basically workforce related rather than management. So is there still the effort going in to finish that with, you know, quality, diversity, ability to speak up, and people getting their workforce really involved and behind what's going on?
Thank you, Councillor Robinson. Good to see you again. You're absolutely spot on. And I think any organisation, including NSFT, is as good as our staff, our workforce, our colleagues. So there's no question. And I agree that in the past that hasn't necessarily been completely recognised. So the large-scale change programmes, the improving culture section of our large-scale change programme is about our colleagues, our workforce, how they are supported, but not how they're supported, but also how they work to support each other as well. So freedom to speak up is a good example. It's a national approach to giving people a route to speaking up with confidence. They'll be listened to and they will be safe in doing so. This time last year, we were transitioning into a new Freedom to Speak Up service. We had that service provided by an external organisation, and we felt we needed to really much more take ownership and responsibility within the organisation. So we have developed a local our internal Freedom to Speak Up service, but by doing so, we now have 52 Freedom to Speak Up champions threaded throughout the organisation, of people who themselves have come forward and said, I would like to be a Freedom to Speak Up champion. So having the ability for people to reach out and speak to people they're confident and familiar with, or through the Trust Guardian service, is meaning that people are speaking up and that they are getting good responses. And then in addition to that, we have also launched an initiative called Dear Caroline Donovan, who is our Chief Executive. So anybody, whether it be anonymously or not anonymously, can contact the Chief Exec directly, and with the concerns or issues or positive things they may want to, they always get a response, and it's always followed up and addressed, or feedback at the very least given if what they've raised isn't necessarily realistic. So the level of feedback that our staff are getting with Freedom to Speak Up is so much more comprehensive than before, and that generates a feeling that is worth speaking up because you get listened to and you get a response. So that's one example that you mentioned. The other is culture in the organisation, and race equity, which Tom made reference to. So we know there is a culture of disparity, where some of our colleagues, particularly those from a global majority, don't get the same opportunities. They're treated differently, and in fact they are experiencing abuse physical, racial, verbal abuse towards them from service users and carers, and that is evidenced through our staff survey. So one of our biggest priorities, so if within the 12 large-scale change programmes, this is one of those that's right up there, is if we do not tackle race inequity within our organisation, our staff, our colleagues, will not be able to work to their optimum. And so we are absolutely seeing that as a massive priority of role modelling as leaders, but also developing, supporting, challenging, enabling our colleagues from a global majority. And we've just come from our executive meeting now, and we are about to embark on what's something called reciprocal mentoring. And this is for our global majority colleagues, where they have the opportunity, again, self-selecting, so nobody is forced to do this, to be mentored by a senior colleague within the organisation. Now, I have had the opportunity to, over the last year, to be a reciprocal mentor for a colleague who's more junior than me and is from a black minority ethnic background. And I've learned so much from him. I've learned from him the experiences that he's had over the last 10 years of being a black person trying to develop and trying to progress in their career, and the barriers that they have faced on a continuous basis. And the inspiring elements of it is they're still going, they're still positive, they're still trying to be really good advocates for service users, colleagues, and the organisation. And this has been despite how he's been treated. And so we have this opportunity through reciprocal mentoring to actually support people, but learn more so as well, learn ourselves about the impact of us who with white privilege have never experienced those discriminatory behaviours in the same way. So there's just so much we could talk about. And I would say this isn't unique to NSFT, but what we're doing, I think, is being really forensically focused on tackling these issues.
Thank you. If I may, I just say, it's nice to hear, and I do get the feeling you begin to move forward as a team rather than them and us, which I think is important. If you can get your staff to feel that they belong, they can speak out, they can make suggestions to improve things, because other people at the workplace, they know what goes on. So, yeah, I'm quite hopeful. Thank you.
My microphone on. Now, Ed, I better call you Councillor Thompson.
I know these efficiencies that you've got. So how firstly have they been calculated, and that they can be made, and how realistic are the efficiencies, do you think, or are they fully realistic? So, yeah.
Yeah, absolutely. So I think in the pack and on the slides we've presented the position as is pretty much today. So the whole NHS is currently going through a planning round, and we're in the middle of it at the moment. So the information that you have is just where we're at currently. But at this stage, nothing has been finalised, nothing's been agreed. So the gap, the 8% gap, which is £28 million, that's reflected in the pack, is just where we're at, but we don't have all the information to hand at the moment. So there is still work that we are doing with our commissioners, so the Integrated Care Board, which is helpfully coming together, which is great for us because we are Norfolk and Suffolk, and they will be the Norfolk and Suffolk Integrated Care Board, so that's fantastic. We're still working with them to understand what the total number is of money that they're going to be giving us. From that, the gap will be determined. Now, for the last few years or so, we've achieved a 5% efficiency target, which is around an £18 million gap. And I would also say that all organisations have opportunities to be more efficient and effective and find savings in ways that actually sometimes can be better. So if I just use a quick example, we've just reviewed all of our corporate services in the last 6 months or so. And part of the reason for doing that is, being honest, we have needed to save some money, and that's backroom function savings, so there's a positive opportunity. But in doing so, we've got our corporate structures right, so that they are there to be really impactful and supportive of our locality services, which are our frontline services. So we are saving £4.4 million full year effect on our corporate function. That's not insignificant, for example. So there are opportunities in every organisation to find efficiencies that are appropriate and good and can make a real difference. And that sometimes requires some tough decisions to do so. For us, 5% is the level in which, as a board, we are comfortable, that we think is realistic and won't have an adverse impact on our services that we provide. So we've got that 3% at the moment where we wouldn't be comfortable. But that's the work that we're doing with our commissioners to say, right, we need to understand how much you're going to give us, and then actually how that brings that gap right down towards our 5% position, which is the discussions that are currently taking place. Does that make sense, Councillor Thompson?
Yes, I suppose.
I think it's work in progress. We're in the middle of it. We're not at the end of it. Tom?
Yeah, I was just going to add, in terms of the process, so the 5%, we've been kind of planning for that to be the case for a number of months, so that work's been quite well developed. And in terms of our efficiency programmes, our locality leadership and our locality teams, so our operational teams, work with finance to identify opportunities. So that goes through quite a managed process, including impact assessments to understand if there would be a positive or negative impact on services. And there is good kind of national information that we can use and benchmarking data and things that can help us with that. So that bit is quite a well planned out piece. We then get to the last kind of gasps before the end of the financial year, which is this part of the planning round where we have to do lots of really close work with commissioners, which is where we are now. So.
Is there a danger that you might have some effect on the quality of the services if you're not careful? Have you?
Yeah, I'll start. I think there's always a risk, so that's why we do the kind of risk assessment, and why that assessment includes our clinical staff, clinical leadership, operational leadership, as well as corporate leadership. It's not, I want to emphasise, it's not finance-led and us having to deal with it. There is always risk, I think. I think we are relatively comfortable with the schemes we've developed that get to our 5% mark, and they will deliver those savings recurrently. It's that final bit where, as a board, we don't want to risk the improvement the trust has made, and our commissioners don't too. You know, our commissioners are very supportive and really do recognise the need for parity of funding and support for mental health services. So that's where we're working through the final kind of trickier bit.
Does that have to happen by the end of your financial year, which presumably is April?
So there's a submission that needs to be put in mid-February, and that's a national timescale, so there's nothing locally determined about that. So nationally we have to submit by the middle of February. There's a very specific date. So that just means now, over the course of the next few weeks or so, there's continued dialogue and discussion and negotiation with our commissioners. But part of it is that they're still understanding what the allocation that they're proposing to give. So that is part of the answer. So we're still working on a level of the micro detail isn't concluded yet, and that's perfectly understandable at this stage. We're early in that sort of conversation with the Integrated Care Board.
Councillor Lockington.
Thank you, Chair. Of course, I have to touch on something which you touched on in your report, and that is the sad death. You know, it's wonderful to hear how you're now working with families so that we don't have to have these very sad stories, because it was not easy to read newspapers at that time and listen to meetings. But it doesn't really tell us what you learned in the report. Is there anything you could share with us about what you learned from the outcome of the work you've been doing with the families? And I have another question, if I can take it. That's where, under improving value, you are putting in a new patient's record system. Now, we know that we've got an NHS app. The hospital, the Ipswich and Colchester Trust, has put in a new system, so they can say they can talk to people in Cambridge and so on. So the new system you're putting in, can that actually talk with all the other systems, or does the patients have to put in more information every time when they go somewhere? Thank you.
Okay, yeah, we'll take the second one. We'll take the second one first. But yeah, so we and we've had conversations with SNF, the Acute Trust, because they're a bit further ahead in their implementation of their electronic patient record. So we've gone through a lengthy procurement process, and the record that we're going to use is the record that's used by the vast majority of primary care. So for us, there's a fantastic opportunity for our patient record to be fully integrated with primary care, which is where we have most of our referrals and most of our interactions. I think that's a really good sign. We're moving from, we already are on an electronic system, moving to a new electronic system, so there will be the transfer of data and information. So hopefully from a service user perspective, people don't notice any kind of difference in provision. The ability for these systems to talk to each other, which is blindingly obviously important to all of us and our populations, has been a challenge for the NHS and a real frustration. And I think, if I'm being really blunt, it would have been helpful for the centre and Whitehall to have mandated stronger integration. But I think organisations that provide these systems are now recognising that, and the integration is much stronger. We do have the steer about the NHS app being the really key driver for change for service users, that they can use that app and be able to put any information and receive support and information and care from different organisations through one app. So that is the focus. I think this electronic patient record will help us get there. I think some of these things will develop over time. So the 10-year plan talks about that change and the use of the app. I think the app will each year become more and more useful till we reach a point in time where it is the first place we go. But I suspect we're all a few years away from that for now. The alignment with primary care is really exciting for us with the use of our system and primary care system.
Could I just come back on that one while we're at it? As GPs are sort of self-employed and run their own businesses, is it the system that all our GPs in Norfolk, Suffolk can log into?
Yes, that's it, and there'll be the transfer of data. So it's not quite all, I think it is something like 95%, and we're quite fortunate, but in other parts of the country there's a much more fragmented system where GPs are using a number of different systems. In Norfolk and Suffolk, GPs are using the same system much more regularly, so it's something like 95%. There's a couple of others that aren't, where we will try and develop other ways to make sure the data is integrated for patients.
Thank you. I'll just pick up the Learn from Deaths review. So as the paper talks about the review of all of the deaths over a 4.5-year period, you'll remember in the press, in the media, there were concerns about why people were dying. So the review that was undertaken of every single person who died under the care of NSFT, or whilst they were in the care of NSFT, or in the 6 months before that, was enlightening information. And it obviously contained information about some people who had died through what's called unnatural, unexpected causes of death. But what it really also, in addition to that, demonstrated was other causes of death for people within that cohort. And what's really come to life as a result of it is us understanding in much more detail how people died and why they died. And they died predominantly of physical health causes. Now, there will be some within that cohort of people who died of end-stage dementia, for example, but actually understanding that people were dying of cardiovascular disease, respiratory disease, obesity-related illnesses, smoking-related illnesses, cancers, really made us very alert to the fact that the inequalities that are experienced by people living with serious mental illness, but also those with a learning disability or autism, even though it's known nationally, people with a serious mental illness die around 17 years younger, and people with a learning disability or autism die 20 years plus earlier. That's known nationally. But actually, it isn't necessarily, when I say then, it's not appreciated that actually many people are dying of what could be preventable, or at the very least better treated, and prevent early death related to those. So if I just give a simple analogy, a number of our population may die of cancer. We know that. But there are cancer screening programs in place in order to pick this up early. There are campaigns to encourage people to go to their GP if they have particular symptoms such as blood in their urine or coughing, continuous cough that's not going anywhere. But what's a barrier to people with autistic people or people with a serious mental illness is they may be fearful or choose not to engage with these services. So it could be that they then don't get diagnosed at an early enough stage to receive treatment, which for the rest of us could be quite simply treatable, but they've missed their moment. So it's a real example of physical health causes that are exacerbated by the inequalities experienced by people with a serious mental illness or a learning disability or autistic people. So that, I don't think as an organisation we'd really appreciated the benefit of the review of the 4,500 deaths would give us that level of detail to say we've got to do something about this. And so health equity, which is the reverse of health inequalities, we're aspiring for health equity, is one of our 12 large-scale change programmes that was described on the slides. And my role has been introduced, a Chief Patient Experience Officer. My role is also to hold the health equity portfolio within the organisation. There is much that we can do ourselves for our service user, pay better attention to people's physical health activities, that sort of thing, supporting them to engage with mainstream services. But actually big part of the opportunity is to work with the partners in the system. So many of the service users who experience these health inequalities, they may have housing problems, for example. They may be higher users of drug and alcohols, and therefore how we support and improve and work with partners who deliver those services, how we work with the police, how we work with the public health teams within the local authorities and put focus and priority on addressing these health inequalities. And for me, that's been one of the biggest gifts from this review, is that we are now openly talking about the enormous inequalities that have been experienced for years. But I think nationally we've tolerated those, and it's not good enough anymore. So the voices of the 4,500 people who died, they have come through this review, and their legacy is to contribute to how we as a system, but driving force through our organisation, champion and represent this group of patients and say this is not good enough for our people. And then in terms of a few other benefits of feedback that's come back from working with service users, working with the families and carers of the service users that died. There's so much I can talk, and you know I can talk. But the listening to families, there were examples when the voice of the worried voices of families and carers weren't being listened to. So the Carers Charter is a good example of something that's come from carers who've said, we want this charter, we want to be recognised, we want to be listened to, and we want to have they have legal rights, but actually there needs to be a much more meaningful engagement with carers within the organisation. some of the clinical transformation programmes, feedback that we've had from the families and carers of people who've died is our crisis services were not good enough. They were inconsistent. They weren't necessarily as responsive. They didn't listen. So we're transforming our crisis services. And even when people do die, the level of support the families are given. So we now have family liaison officers who work within the organisation that provide that interface between the organisation and the families at the worst possible time of their life, and do so with huge compassion and empathy and support. So it's not just about being kind, but it's actually helping. And the feedback that we get about the family liaison officers is just fantastic. It has real meaning. There's so much more I could say, and I'm sure you want to move on. But yeah, it's been a gift, I have to say.
Can I very quickly add something on about the physical health piece? So it's a huge area of inequity, and actually in Suffolk I think there's been some really good joint working. So in all people with severe mental illness, the government asks for them to have an annual physical health check. And quite often this doesn't happen because it's quite hard. Primary care should be delivering that, so GPs should be doing the health check. But it's quite hard to get them into a clinic, potentially. The ICB and primary care themselves and ourselves kind of recognise this gap, and we have a team commission that go to those who are hard to reach. So primary care complete this health check for most people, and we then go into people's homes for those that primary care can't reach. And I think I saw this morning that the data is that we're 88% in Suffolk for this measure. I think it's the highest in the country. If not, it's almost the highest in the country. We then have a really good pathway where we might spot an issue, and we work with Suffolk User Forum, and they can identify potentially the voluntary sector support that this person might need to help with high blood pressure or exercise or well-being related kind of issues. So I think it's a really good example of the Commissioner and different providers, including the voluntary sector in Suffolk, have spotted a problem. Obviously, we're 88% now. We've improved that. For this to have real impact on the population, we need years of this to happen, so that we're seeing people, you know, so people have their moment and we catch them at the right moment. But I think it's a really good example where together in Suffolk, the right organisations are working together, and this will have material impact, I think, on that population group.
Are you happy with that, Councillor Lockington? Are you happy with that? Yeah. Can I just ask, there's just one word that came, which worries me, is housing. I've been involved in housing crisis for most of my work with the council, with the borough, and I just wondered how you deal with that, because I'm dealing with a case myself at the moment where a girl has got such dreadful mental health problems, and she's not looked upon as a priority. And so, you know, it took a lot of persuading for the council to actually put her into one of their hostels as opposed to sharing in a mixed house. And I just wonder how you deal with that, because I can see how much it drags somebody down, and also with mould and all the rest of it in property that's so unrecognised and so awful for those people.
Yeah, thank you. We at the moment, we have to try and deal with it on a case-by-case basis, but that takes more work and effort than is necessary. So there's two elements to it from my perspective. There's probably more than that, but essentially we have people who are in inadequate housing that can't help but affect their mental health, but and their physical health as well. You mentioned mould, for example, that has consequences. And we can try and advocate and support individuals, but actually that's not treating the root cause of the problem, which is the inadequate housing. Then, of course, we've got a group of people who have been made homeless, and that might be because, probably down to their poor mental health, they may have broken their tenancy, for example. They've not paid their rent, or they haven't looked after the property, etc. So they lose their tenancy, and then that perpetuates the problem. And we reviewed our inpatient beds last year, just a census back in about June, to understand who is in all of our adult inpatient beds. And what we realised is we have about a ward full of people without their own home. So they were staying in inpatient settings whilst we were trying to work with partners to find them somewhere that was reasonable for them to move to. So every day, our colleagues are working with service users, families, other providers like housing associations, the district councils, etc., trying to find solutions for them. So as part of our health equity approach, that is going to include how do we work as a system with all of the district councils and the housing providers to come up with a way of being much more responsive, supportive, proactive, so that housing, because let's face it, somewhere to live shouldn't be an issue for any of us, and that's us in a room or the people we serve. So how do we work together much more collaboratively to support more effective housing, and try and be much more proactive and preventative in that approach? Now, this is a whole huge piece of work, and I am not going to sit here and tell you we've nailed it. We're only at the infancy of it, having conversations with some of our partners, but this is an area for 26, 27 that we really need to kick off, because it's all of our problem. It has devastating effects on people, and we can't sit there saying, well, that's a housing problem, that's the district council's problem. It's all of our problem, and we can only then be part of that solution if we work together.
Councillor McLaren.
Chair, I think Councillor Shaw put her hand up before me.
Thank you, Councillor McLaren, and thank you, Chair. Yes, several of my thoughts and questions have sort of been answered already from matters that have been raised. I have to say that the whole picture you're giving is really promising, and I'm just have to express the sort of admiration for the very searching work that you seem to be doing. The message is coming very clearly across to us. We've had some very useful infographics and so on. I'm just wondering how well that message is reaching the wider public, not just talking about the service users and the carers, but the people who I sometimes hear from who say, oh, there's no point in contacting them, we won't get the help. And that very negative attitude, which is still hanging around. And I'm just wondering how you deal with that. So that's my first question. And secondly, if I may, it's about the councils that you're now setting up. And the first one's today for... First locality one, yes. I think that is excellent, because that was obviously a massive issue where you did have people sort of involved in the past, but this sounds as if it's far more proactive. So that's how proactive is that? And how do you find those volunteers to be on that council? Are they people who are the obvious ones who always join things? Or are you managing to reach people who are less easy to reach? And how practical are their contributions on that council? Or how do you project that their input will be useful in the future? What can they add? What value can they add? Thank you.
About the partnership,
yeah,
and then I'll do the council.
Yeah, if I take the first one, so I think the first thing to say is we're an improving organisation. We're not an improved organisation, and that comes back to the first question we had about the well-led position, and that's why we're so keen to have the CQC. But not many people say they want the CQC back, but we're keen to have them back this year, particularly in that freedom to speak up area. So we're still improving, and I think the trust has had a real history of underperformance and maybe tentative improvement, and that's regressed. And I think probably, the wider public are looking at things potentially suspiciously. Can we keep up this improvement, particularly in the context we're operating in when demand is increasing? And I think that's something we need to work through and show that we've got this continued improvement trajectory. So I think that's a fair position. I think the efforts we're making with partners across the health and care system, but also then into the voluntary sector and beyond, I think will help, because I think it's their voice when they're speaking to the public and their own service users. It's their interpretation of NSFT is really important for those who maybe don't interface with the organisation directly. So I think that partnership work's important. I think that's the other, in terms of that partnership work, that's where I think our localities are the key too. So as well as the locality councils with service users and carers, it's making sure our locality leaders are really plugged in with local voluntary sector organisations, the alliances, so that we've got closer relationships. They don't feel like they're organisation to organisation. They feel like they're individual to individual. And, you know, our localities have been established for just under a year now. I think that's something that I'd hope will strengthen over the course of this year.
Yeah, thank you. I think the history of the organisation is we've been very inward focused and just trying to deal within the and even before I joined the trust, but just looking internally rather than looking externally, and that's made the issue in terms of relationships, confidence, trust much bigger. But there are a few things that Rebecca, our Director of Communications, who works for Tom, the amount of work we've done in terms of trying to proactively engage with the public, our partners, you know, there's stakeholder briefings, there's blogs, we try and push out good news, because we do need to influence people across Norfolk and Suffolk to have confidence in the services, and when they see positive news, that all one by one all adds to, oh, things are changing, things are a bit more positive. And so it's a purposeful programme of being better partners, being a better provider for the people who we serve, and we can't just assume that's going to happen. It takes a lot of hard work to do that, but I think we're doing making reasonable progress on that. In terms of the service user and carer councils, one of the things you mentioned about was how proactive they are. So the trust-wide council's been in place for a year, and it's developing, evolving, and we're putting in support from an external organisation to help develop them. But how they describe themselves, not how as I would describe them, but how they describe themselves, is their role is to have influence, and that is continuing to progress. So, for example, our two co-chairs, one of them sits at the table in our trust board, for example. So they are there to be able to freely contribute to the way in which the board operates, and have their voice representing the council, who represent service users and carers, heard. So what I would say is it continues to develop. It's an evolving process, and our locality councils are literally happening this week. So this is about, it's interesting, we had a meeting before Christmas where we met many of the council members from the localities, and I didn't recognise most of them, which is a good sign, because that means new people are joining in. We've advertised for people to come forward. At our AGM in October, the council members themselves had a stand at our AGM encouraging members of the public to join. And we're also reaching out to organisations within the geographies, within the county footprints, but also the locality footprints, for them to come, because they represent people as well. And in my last point, in terms of those people who are less easy to reach, I think that's an area we haven't nailed yet. So the demographics, the visible demographics in that meeting it was a predominantly white female group of people. So we have to work harder to reach people that are currently not represented, and their voices are not heard. And it's not for us to wait for them to come forward, it's for us to go out and actively engage. So that is part of the progression in terms of the development of the councils for this year.
Thank you. Councillor McLaren.
Thank you, Chair. I've been on this committee 6 years or so, and when I first came on the committee, how your trust was and where you are today, I've got to say well done on all that hard work that went into that. But what has happened recently is your organisation, looking at the locality leadership structure and the board and all of that, is more complex than it was before. And I'm interested in audit and risk management, and I see that one of your directors, I think he's a non-executive board director, chairs audit and risk committee. Now, risk management is everybody's business. Fit people, fit building, fit systems. Could you explain to me how you manage audit and risk management within this new, large, complex organisation? Thank you.
Yeah, I think that's one for me. Yeah, so it's a really good question. I think what we try to develop with the locality structure is a real clarity where we have an organisation that grows and builds up to ultimately audit and risk committee. Before the locality structure, we actually had 11 care groups. So in a way, the organisation was more complicated, and this has provided some clarity. We've established a governance structure and a rhythm from team level through to locality level, through then to organisational level, to try and create a really clear hierarchy, because we thought that previously, from a governance perspective, there were sometimes some blind alleys or areas where risk in particular could get stuck at a level and not get through to committee and board. So we've done a lot of work in this space. The governance large-scale change programme has been a programme for a couple of years that's really been focused on establishing these clear governance processes that improve ward-to-board governance. It's also been focused on really being clear about the role of committee, and it is committee at board. Committee should be I think the organisation brought through too much into board, which meant the board didn't have the depth of understanding it needed to make decisions. Committee should be operating at that level, only then escalating to board. So I think that creates a better flow of governance decision-making and risk escalation. We've actually adapted the large-scale change programme now to cover risk in particular, because risk has been an area of concern. That's more been an area of concern in terms of local understanding of risk, local management and ownership of risk, and how we really embed that culture. So we've got an improvement programme, kind of work stream focused on that. I think in terms of maturity of the organisation, I think colleagues, down to the front line, are better at identifying risk now, but it's really about ownership and taking that risk through and mitigating it so that we can be assured that work is kind of a live piece of work. As well as audit and risk committee, we do have a group that operates at an executive level, meeting more regularly to keep assured on a more regular kind of cycle of key risks and escalation of key risks. So that's some of the process, but it is an area that we've identified we need to do further work to really give ourselves assurance.
Just follow that through. So if I was a part-time care assistant, what would I understand about audit and risk?
Yeah, so I think if you were, you've described it, a frontline colleague, they should really understand about incident reporting and risk reporting and the process there. So we have a risk system for all members of staff. They should understand how they use that system, what they do. They should understand who their line manager is that they need to communicate with. So that should be kind of their level, and then we have the governance processes built around that. We would expect our colleagues to understand certainly that risk and incident reporting, and we need that to be done quickly, efficiently. We also need people to recognise that by reporting a risk or incident, that isn't pointing the finger of blame, that's doing the right thing to make sure that an issue is addressed. So that'll be my expectation of a frontline colleague.
Wonderful. Thank you.
Thank you. And I think our last speaker is Councillor Rowe.
Yeah, going a bit back to kind of the working with communities and stuff, and the parity between mental health and physical health, and kind of putting into the new system, how well does that all kind of work together? Because, for example, I'm non-binary. Physical health services, I do not work on the system. It is much more focused on kind of binary gender, and so is kind of for your new system, is it actually reaching a parity, or is it just kind of going, okay, we'll kind of use what the physical, like, well, I say physical health, despite the fact that it's not as simple as separating out the two, but generally the physical health side have been much more focused on certain physiology rather than whole person stuff. So there's a bit of that, and kind of it builds in to a bit more broader culture of like trans people aren't being believed. You have you have kind of high up decision makers in government kind of saying that autism, ADHD are kind of overdiagnosed, and there's also people who fall through the gaps. So like there's huge waiting lists to actually get diagnosed with ADHD, as well as filling out a long form, which I know people find difficult inherently because they have ADHD. So yeah, how like does because you've got measures saying how well you support people, like CQC, but how well does the bit where you will? It sounds like you will kind of you work well enough with people to show you'd see where people are falling through the gaps, but then how well does that actually? Do they move through the whole system rather than just getting blocked because they don't fit with what is being defined basically by others? And also on a slightly different note, it could be good if you could promote HRA needs to be sorted out for housing revenue account for district. That's just from what I've seen on district of that is one of the biggest issues with providing housing is it's a really unsustainable bit. So yeah, if you talk to your contacts in district, they'll be able to have a long discussion about how that affects housing.
Shall I start? I mean, I'll start on this. I mean, there's so much there, and actually you're picking up on a lot of the live discussions that are happening nationally in terms of ADHD and ASD. You mentioned trans 2, waiting lists for what we call neurodevelopmental disorders, including ADHD and ASD. I think overall we're trying to work towards parity in recognition of mental health and physical health. I think this is a slow-moving piece that is moving in the right direction. I know that our acute partners really recognise that a lot of the complex people they see, who they feel the most pressure in terms of A&E attendance and people who visit regularly. They realise now that often they've got complex conditions, those people, that include a mental health element. So we do feel like we are being brought in more by those partners, which is a really good sign. I think the government recognises some of this to a degree in terms of some of the investment and commitment it's making in its 10-year plan, that we need mental health services to be closer to accident and emergency as a front door to identify people. So I think that's a good sign. However, I do feel like the parity in funding is still a challenge, and if you open the newspaper, the key metrics that will be presented to you will be in relation to cancer weights and weights for routine operations and probably accident and emergency. They will still be more physical health focused. So I think we've got a really enlightened commissioner. I think we've got a really enlightened partners actually in physical health. So I think we're making strides, but reaching for us to sit and say we've reached parity in mental health and physical health will take a long time. I think if we look back 100 years or 50 years, the treatment of those mental health conditions is barbaric, would probably be the word we'd use. So we've moved quite a long way, but there's further to go. I think your point about ASD and ADHD is a really interesting one, because what we've seen here and nationally has been a huge increase in demand for services, which has caused a huge increase in waiting lists. Now, there's probably multi-factors to what's been a trigger. We talk about social media, the impact of COVID and the lagging effects of COVID maybe, and the kind of modern world, as well as improvements in mental health medicine and understanding of conditions. I think it's a good thing the government are looking at it, because I think we do need a review. We will feed into that review if asked, but I hope it's a rounded review that is really focused on understanding the need and those conditions and how they're best supported, rather than the suggestion that it's about just slashing waiting lists. It needs to be focused on what's the need we have in our population and how do we meet it. So it's going to be a really interesting area that hopefully we can contribute to through our Chief Medical Officer or others. probably missed a few bits there, Miles. Councillor Rowe, sorry.
Yeah, part of it was kind of you saying you're using a system that connects with other services, and kind of does that actually kind of include the mental health side of stuff, or is it still very much geared towards physical health? So when people kind of get asked for data to be like, so kind of it puts it, or they look at their records, is there a disparity with what their kind of the approach taken by mental health services and then what's on the system, because it's trying to tie in more with physical health systems?
I'll start on answering that one too. So there is still a challenge. If I take that example of physical health screening for those with severe mental illness, so our team review all of those cases. They have access to currently 57 different systems for each of our primary care providers. In time, they'll have one set of access that gives them sight of it all, which will be some of the changes we were talking about earlier. But when they go in and look at those records, there are still examples of people who are living, living well, living lives that they're happy with a long-standing condition that is being well managed, and those people sometimes get flagged as needing urgent or immediate support when they're actually in a good, living their life well. Whereas there's others who may be escalating, and maybe mental health intervention is the right thing, who it's not picked up on. So that there is still more work to do with primary care, but also secondary care, for them to understand, the different roles that we have in a system and the role a mental health provider has. I think there's still a kind of education piece, that we can help provide to our colleagues in other settings.
Thank you. I realise we're running behind time and that you have to go to your next meeting. So I'd like to thank you so much for coming today, and it's been so worthwhile. And as everybody has said, all the members have said, you've done remarkably well, and we're very proud of you, and we look forward to you coming back, hopefully in a year's time, to bring us up to date. We're going to go through recommendations now, but I understand you need to go, so please feel free to either stay or depart, whichever suits you best.
We'll stay for the recommendations if that's okay, and then we'll slip out if that's okay.
So, going to recommendations, obviously we'd like to ask NSFT to come back in approximately a year's time as a recommendation. And we also talked about, when we had our own meeting, the Better Together bulletins, which we get, but it's not widely spread across the council and the councillors. And I think a recommendation would be good to allow that to happen. And I thought I picked up that perhaps the general public are not actually aware about how they could come to you, as opposed to their GP needs to be able to say, if you've got a problem, who do they contact? Because going back to the young girl I'm helping, she had no support whatsoever until, various people intervened. And it was like a desperate situation of her sleeping in a car overnight. So it's just that lack of information. It seems, if housing is really poor, somewhere along the line, we need to contact the boroughs and the districts. Any case, I'm talking too much. Councillor Robinson, you have.
Thank you. I just think it'd be nice to congratulate NSFT on progress made, but ask that they keep going. Keep improving. Keep going forward. But I think congratulations thus far, I do. Thank you.
If there are, because I was talking about the problems that they might encounter, the service is deteriorated. If there are any problems, might it be good for us to receive a report about that or something? Yeah. Okay.
we're happy. Catherine is busily making notes on this. Has anyone else got anything they think that we should have a recommendation? Is there anything that we can do to help? The integrated IT system, I think we're all a little bit concerned about. We've all had personal experience of not getting to the right person, etc., etc. So I think that's quite important to see how that progresses, and maybe an update from yourselves to us in 6 months' time to say it's integrating, if that makes sense, and compatible with SNEF as well.
Just in terms of that, we've got a 12-month mobilisation programme. It's quite a complex, as I think that's all our fears, is exactly the same. You know, it's quite a complex process. I think we're in a good position that we're transferring from one electronic system to another. Some trusts nationally is now moving from paper to electronic, which fills me with horror. But I think certainly we could give an update as we go through the mobilisation, but that final mobilisation will be complete at the start of not next financial year, the one after. So when we come back in a year's time, we can give a more detailed brief as to progress, certainly.
That'll be fine. And Catherine, do we go through our recommendations?
We can do. I mean,
So we've said about coming back in a year, and we've talked about the Better Together bulletin.
yes.
And I think that's it. If we can word anything, we can share that with you, and you can comment on it afterwards.
Yes. I don't think anything else.
Yes. Yes, Kath.
I think what would, if the committee feels it's appropriate, what would be really great is an endorsement of the importance of a system approach to dealing with the health inequalities that are experienced by our service users. And just so it's not an action for you to have to do something, except actually just recognise it and endorse that concept accordingly, because not one of us can fix it.
Yeah, kind of on that point, because we see different organisations in Scrutiny, whether to like have a bit about how they're achieving parity between mental health and physical health for when we have other, I would say the CCGs and stuff, but everything's changing, so I can't quite remember which organisations we'll be seeing in future. But so the onus isn't just on the NSFT to report to us about it, it's how other things working with NSFT or with the same people will help achieve the systemic change.
And thank you again very much indeed. And you have one final word?
Well, actually, it was just that point there. Actually, it's our ICB now, so our Integrated Care Board now. CCGs have been consolidated. They're developing a mental health strategic plan, I think they're calling it. We'll be inputting into that, and hopefully that will show that system approach to supporting mental health. That should be due early in the next financial year, and I think will be really important for all of us.
Thank you. I hope we haven't made you too late for your next meeting. Thank you very much indeed for coming. Councillors, do you want to take a 5-minute break before we move on to the next item on the agenda? think is everyone here? Yes. Just so we do apologise. We didn't realise the first item was going to be so interesting, I suppose is the right word. So community pharmacy services are usually independent businesses contracted by the NHS to provide services for local people. Integrated Care Boards, the ICBs, now have responsibility for the commissioning and management of pharmaceutical services. Core funding of community pharmacies in England has remained static for many, many years. The businesses have been subject to many pressures over this time, and the committee heard in an information bulletin in January 2025 that Suffolk had lost 13 community pharmacies since June 2020. This item on the agenda will enable the committee to consider the progress of efforts to support the resilience of community pharmacies since members last considered the matter in October 2023. So you're very welcome, panel members, and may I hand over to whoever's taking the lead so that you can introduce yourselves. Can you use your microphone? Thank you.
Thanks for having us today. Nice to see you all. My name is Lee Doherty. I'm the Community Pharmacy Commissioning Clinical Lead for Suffolk and North East Essex ICB.
Good morning, everybody. My name's Anna Crisp. I'm a consultant in public health. I work in the Public Health and Communities team here in Suffolk County Council, and I chair the steering group which is responsible for producing the pharmaceutical needs assessment for Suffolk. Thank you.
Good morning, everybody. I'm Tony Dean. I'm Joint Chief Officer of Community Pharmacy Norfolk and Suffolk, which is basically the LPC, the Local Pharmaceutical Committee. So think of a local medical committee where they're representing all 272 community pharmacies across the Norfolk and Suffolk area.
And I'm Simon Morgan from the communications team within the ICB. Nice to see you all.
Thank you. You're all very welcome. I believe one of you is it you, Lee, that you're going to give a verbal presentation as opposed to a PowerPoint?
That's right,
yes. Yeah. So off you go.
So committee has asked 5 questions regarding the resilience of community pharmacy to cover main challenges that community pharmacies are currently experiencing, the issues that need to be addressed at a national level to increase the resilience of the sector, the findings of the most recent pharmaceutical needs assessment, what can be done by system partners at a local level, and how partners are working together to deliver this support. So we have collaborated as organisations working in the system to submit the paper and obviously welcome any questions after I've given this initial briefing. Community pharmacy is obviously a critical part of our local health and care system, increasingly delivering clinical services, vaccinations, public health interventions and advice alongside the dispensing of medicines. However, the resilience of the sector is currently under significant pressure, and as mentioned, local partners, Community Pharmacy Norfolk and Suffolk, colleagues from the Suffolk County Council Public Health Team, and also colleagues from both Suffolk and North East Essex ICB and Norfolk and Waveney ICB have collaborated to provide the paper that you've received. So the pressures affecting community pharmacy have been grouped under 3 key areas. First one would be funding. So national funding reductions have been in place since 2017. That have had a severe and detrimental impact, perhaps, to the sector. NHS England commissioned an independent financial analysis of the sector, and it recognised that there's potentially a £2 billion shortfall to deliver the full economic cost of the national community pharmacy contractual framework. There was, encouragingly, a very significant funding uplift in 2025 to take total funding to in excess of £3 billion. And yet, unfortunately, still the shortfall remains. It's anticipated that rising operational costs have absorbed most of the uplift that was seen in 2025. From a variety of sources, a pressure survey by Community Pharmacy England suggests that approximately 50% of pharmacies are operating at a profit, and that would be broadly supported by the findings of the independent economic analysis. Several contractors having to use personal savings to remain viable, and as referenced earlier, that we have seen some pharmacy closures in Suffolk. So we're about 18 now since 2018. Some of the other consequences of the funding have been that we have seen some reduced opening hours from community pharmacies, withdrawal of non-contractual services, which would include things like the free home delivery of prescriptions, and maybe limited investment in technology and infrastructure. I think it's important to point out that the vast majority of funding for an NHS community pharmacy would come from the national contract, but we do have some local services that are commissioned both by ICBs and by local public health teams. On to the next area, which would be workforce pressures. Recruitment and retention remains a challenge, particularly for pharmacists and pharmacy technicians, or the groups of pharmacy professionals in our geographic rural and coastal areas. The additional roles reimbursement scheme was introduced a few years ago, and that has successfully supported primary care networks and general practice teams to increase and diversify their workforce. So we now have a wider range of clinical professionals delivering services at general practice level, which would include paramedics, social prescribers, as well as pharmacists and pharmacy technicians. But one of the adverse consequences of that perhaps means the workforce has shifted from community pharmacy, or some of the workforce has shifted to fulfill those roles. Recent pressures surveys suggest that staff wellbeing and morale has deteriorated over recent years. But encouragingly, there are some signs of improvement. So we are seeing a growth in cross-sector foundation year training. So that's the training of pharmacists for our future workforce. We are finding through system collaboration that more and more organisations are working closely together to support the training in different settings, which would include experience in hospital, which would include experience in general practice, and experience in community pharmacy. And the idea really behind all of that is to basically increase collaboration and hope that we are fostering a more resilient workforce for the future, enabling portfolio careers with professionals able to work across different disciplines. We're seeing some really encouraging signs in the expansion of the role of pharmacy technicians, which would include changes to supervision regulations, which would allow a greater role of pharmacy technicians in community pharmacy, and pharmacy technicians being empowered now to supply medicines under patient group direction, so a kind of a proxy for prescriptions. And we're seeing that match now with national services and local services. And very recently, we have a teach and treat program. So changes to foundation year training for pharmacists will mean that from 2026, from this year, all undergraduate pharmacists will train as prescribers. And we have a legacy workforce in order to try to maximise that skill set and the potential that the community pharmacy sector has. So we've collaborated with ICBs across the region and obviously system partners in order to try to help upskill and support the training of pharmacists who are already qualified, who are already in the workplace, to get to that level. And the last element of the challenges would be around the medicine supply chain. So pharmacy teams are reporting spending several hours every day trying to find medicines due to shortage challenges. That's obviously time that could be used for the delivery of other services, patient-facing roles. There are concerns around the current reimbursement mechanisms for the reimbursement of medicines. That's been discussed in various forums. The model operates on a swings and roundabouts process, such that the idea is that there is an element of dispensing profit as well as supply, but many pharmacies are reporting situations where they're dispensing medicines at a loss due to challenges in securing the medicines. On terms of national action, I appreciate that first opening bit seemed very negative, but that's because we were asked to present the challenges. In terms of national action, Community Pharmacy Norfolk and Suffolk supports the view of Community Pharmacy England, and they have proposed a 4-point plan which would broadly propose national reforms in 4 areas. 1 would be closing the funding gap, 2 would be reforming the medicines supply chain and the reimbursement mechanisms for that. 3 would be continued expansion of clinical services nationally, which would include an independent prescribing service from community pharmacies and a greater role for vaccination. And to embed community pharmacy as part of core modern primary care, which would include integration into neighbourhood teams. In terms of findings from the pharmaceutical needs assessment, every health and wellbeing board has a statutory responsibility to carry out P&A every 3 years, and Suffolk's last P&A was published in September 2025. Suffolk has 127 community pharmacies currently dispensing over 1.2 million prescription items per month. Access is generally strong, with 99% of residents with a car that can reach a pharmacy within 20 minutes and 65% within 20 minutes on foot. There were no gaps in pharmaceutical service provision identified for now or for over the next 3 years in the life cycle of the P&A. We have noted declining numbers of pharmacies and reduced opening hours as a potential risk. Public survey was conducted as part of the P&A and over 1,500 responses were received. They emphasised convenience, stock availability and customer service as the main drivers of pharmacy choice. Although pharmacy doesn't have a registered database or a registered patient population, and that patients and the public can access any pharmacy that's convenient to them at any time for any service, 92% of the respondents responded to say that they have a regular or preferred local pharmacy, and satisfaction with community pharmacy in both Suffolk and Norfolk it remains very high, as evidenced by the GP satisfaction survey. The P&A recognises there are opportunities for increased prevention, long-term condition management and integration with PCNs. I think it's important to point out that Community Pharmacy Norfolk and Suffolk have submitted that access to pharmacy and by increasing access to pharmacy by opening new pharmacies is not always the preferred solution, in fact might not be the preferred solution. Perhaps better to try to support through system partners the resilience of the current sector and the current providers in order to ensure that they can meet the demand, and the infrastructure of what currently is in place will be there for the future. In terms of local actions to strengthen pharmacy resilience, the ICB has worked very well with system partners to try to embed the new services, such as Pharmacy First, such as the hypertension case finding service, and the recent changes to the National Pharmacy Contraception Service. Norfolk and Waveney ICB and Suffolk and North East Essex ICB co-commissioned a community pharmacy integration project, which was delivered by Community Pharmacy Norfolk and Suffolk, and they've delivered strong results and have given us a clear mandate as to how to take the integration of pharmacy going forward. Both systems have got a robust workforce strategy and continue to support national workforce models. There is, due to the restructure of ICBs and the change in the commissioning, the role of the ICB in terms of supporting pharmacy workforce, amongst others, remains slightly unclear at this moment, with an emphasis on the transition towards regional teams, local providers and neighbourhoods. But until that's established, the ICBs are committed to supporting that while we can. Huge immediate priorities are technician workforce development, expansion of independent prescribing, as we mentioned earlier, support to continue to support the legacy workforce, and cross-sector training. And really encouragingly, we have a new School of Pharmacy opening at the University of Suffolk, which again will actually hugely present massive opportunities for strategic development and support for our workforce. ICBs are committed to continuing to support the prevention and vaccination agenda through community pharmacy, maximising their access. An example being in SNE, particularly when the COVID-19 vaccination programme started, we had 8 pharmacies initially. We've now got 86 pharmacies participating in the campaign. Pharmacies will tend to deliver in SNE as many, if not more, vaccinations for COVID-19 as general practice and PCN teams, which is clearly demonstrating how the accessibility of the sector and the acceptance of the public to vaccination in pharmacy is really strong locally. And we're really pleased that SNE ICB has been recognised nationally for its vaccination efforts and has been selected as a pilot for RSV vaccination. So 2 ICBs in the country were selected, and we're really pleased to have been selected, and pharmacies are really delivering strong vaccination results. I think the last thing to say, is that I feel, and hopefully we all feel, and hopefully from our briefing we feel, that we have strong relationships between system partners, between our LPCs, between the ICBs, and with our public health colleagues. Working collaboratively, we can do our best to try and improve the resilience of the sector. I think it's really key, and I think we're all agreed, that pharmacy representation within integrated neighbourhood teams is crucial to maximising the potential of community pharmacy to the public in supporting population health, to reducing inequalities, improving access and supporting prevention. SNE ICB has been successful in engaging in the National Neighbourhood Health Implementation Pilot Programme. I'm really keen to try to see that supported in Suffolk, and community pharmacy, through myself and colleagues, has been identified as a key stakeholder as part of the leadership team. So fully committed to seeing that happen. And I think the formation of the Suffolk and Norfolk ICB provides a big opportunity for us to strengthen strategic commissioning, reduce health inequalities, and embed pharmacy as a core partner. I think that's it.
Thank you very much, Lee. And before we go for questions, Anna, would you like to add anything to the...
A few things maybe. So thank you for covering the headlines of the P&A, and I'm very happy to take any further questions that you have on that. Just from a public health perspective, colleagues may be aware of the recent 2025 report published by the Chief Medical Officer, Chris Whitty, which is all about infection. And he highlights in particular the risk of infections among older populations, which of course is the population demographic that we have here in Suffolk. Not all infections have vaccines, but some of them do, and some of them are very effective. And so just to build on what Lee was saying about the rollout of vaccine giving through community pharmacies, access, we find in particular community pharmacies can be very effective in reaching rural populations. They are well trusted, and some of them also offer a postal service, which also enables that rural reach and people to access care. So just building on what Lee was saying, really, I think these issues are really crucial for the health of the population in Suffolk going forward. So perhaps I'll just draw attention to that. Thank you, Chair.
Thank you, Chair. First of all, thank you, Lee, for a really good summary of where we're at. A lot of the issues of community pharmacy are national based. The cuts from 2017 and then flat funding has left huge damage to the network. Indeed, we say now that community pharmacy is in crisis. That's not my hyperbole. That's the Health Minister for Community Pharmacy, Stephen Kinnock's words, that community pharmacy is in crisis. He described the community pharmacy national contract as a car crash when he took over community pharmacy responsibility with the new government. So we've been facing years and years of pharmacies trying to do more and more for less and less. And that has consequences. I'm sure all of you have run businesses or acutely aware how businesses run. That means cutbacks, that means lack of investment, that means struggles, that means stress, that means heartache. And for some, that's meant the end of a business. We're now reaching a point where if things don't change significantly nationally, then we will see more and more pharmacies starting to close for good. And the risk of that, of course, is that where they're closing most is in areas of highest deprivation, because they're not able to maybe supplement their incomes quite as well with private services, because obviously in a deprived area there isn't the money to spend. So pharmacies are closing disproportionately in areas of highest deprivation, which should be a concern to everybody. The three things, the funding, absolutely. I mean, ultimately, the government itself says it's well over £2 billion short of actually what it should be funding, and that's called a global sum, and that goes into paying for everything that community pharmacy does. So if that was increased a bit last year, they also added in the Pharmacy First service and other services like the contraception service, etc. So it wasn't like for like increasing funding, it was funding for doing more work. And every business reaches a capacity, and unless we have the money to invest in staffing, new premises, refits for more consultation rooms in our pharmacies and things like that, what we know we all need, then we're not going to be able to carry on adapting to the aspirations of government and our aspirations and the ICB's aspirations to become a more clinical point within the community that people can access. And the loss of community pharmacy to your communities, I'm sure I don't need to tell you, the loss of high street services are a huge concern to people, and if a community pharmacy closes in the high street, then I would indicate that that high street is about to die. So the societal impact, the day-to-day social work that we do, pharmacies know their people. Quite often, somebody going out to speak to their pharmacy team might be one of the only interactions they have that week, and they can do that without an appointment. So we are actually incredibly grateful. The positive thing is local commissioning. Until 2 years ago, we were out with NHS England regional commissioning, which wasn't commissioning. It was barely contract management with a stick. Now under local commissioning, we have people that understand our community pharmacies and are really trying actually as commissioners to work with us to improve the resilience of our pharmacies and to help integrate the pharmacy services. Because if the pharmacy services are paid nationally and our pharmacies don't do their fair share of those services, then they're not getting their fair share of the global sum. So therefore our pharmacies in this region are not earning as much as the average pharmacy across the country. So the integration, so that pathways actually send people to pharmacies, that GPs refer to pharmacies, that patients know about the services that pharmacies do, all that work that we are increasingly doing together is really actually vital to the resilience of community pharmacies. And actually, these people are the solution, not the problem. And of course, our concern is that with ICB cutbacks of 50%, that having years of not having those specialist skills within the ICB that really understand us, that those will be again lost. And that is a huge concern to us. Lee also mentioned workforce. The ICB has been incredibly helpful with workforce. And under current plans, community pharmacy workforce does not fall under the new ICB remit. It's supposed to fall under some more regional remit, but we've had no details whatsoever about what that looks like at present or how it will be developed. And you won't be surprised that obviously rural areas like Norfolk and Suffolk disproportionately suffer with workforce issues for skilled healthcare professionals. So it's not a case of, we want what everybody else has got. We actually need more help than others to maintain our services. So that is a concern that we have documented. As I say, the positives are that we are increasingly working together as local units, and the vision that I think we all share for community pharmacy is absolutely positive. It's just how we get from where we are now and all the risks. We're about to go into a national negotiation with the HSC and the government and NHS England. That negotiation has been put back already, but the outcome of that negotiation, I would suggest, for a lot of pharmacies, won't just be kind of, oh, that'll be interesting. It might decide whether it's still open or not this time next year. And of course, the risk of all that with your P&A is that saying where are your needs for pharmaceutical services. The risk going forward is that becomes a wish list of the unaffordable, that you're wanting things that just can't be delivered. And we are reaching that tipping point. And as I say, that's not my hyperbole. That's what an incoming health minister has actually said. Thank you
very much indeed, Tony, and thank you all for that. Members, yes, Councillor Robinson.
Thank you, if I may. I'd like an observation and a question. The observation is, I think we've all experienced in the last year or so, particularly shortage of medicines and chemists not keeping the stocks, presumably partly for cash flow purposes, reduced stock holding, and the diversification of chemist services, so some to an extreme length, which is welcome. But what I want to ask you is, what do you need from us? What do you need?
And that is a really good question, because somewhere between 90 and 99% of a pharmacy's turnover is NHS income. Obviously, if you're a massive Boots and you've got 3 floors of retail, then obviously that's near 90%. But ultimately, the vast majority is NHS income. And that is obviously not within your control. It is within your control to, share the concerns that you may have from what you hear today with health ministers and other people, so that, going into negotiations, they understand the fragility, especially in rural areas. There tends to be a metropolitan tint to negotiations where there's lots of pharmacies in London, and that, they don't actually see into the rural areas beyond, where there might be only one pharmacy in a village, etc. You lose that pharmacy, then that's a severe impact. So I think stressing the need for a wider picture than just the metropolitan look of London is also important. Beyond that, I think, as I say, I'm not here bringing concerns about the local systems and the people we work with. Actually, far from it. I think you should have picked up. I'm actually really quite positive about that. However, there are changes ahead that none of us on this row here know the answer to, about the ICB reconfiguring, what happens to the pharmacy team that has been so integral to our resilience, and what happens to the workforce to help us support our pharmacies going forward. And, there are real positives with that. Our technicians are allowed to do far more. They're actually been empowered to do patient group directions and offer some services under their own registration. They're registered with the Pharmaceutical Society. So it's how we help grow that team so that we can diversify, leave the pharmacists to do what they absolutely need to do at the top of their skill set, and empower other members of the team. But all that takes 2-3 years of planning and support, and individual businesses just acting alone. It's really difficult to actually form a cohesive plan around that. So I guess the clues in the scrutiny, I think it's just, you know, continue with us to hear what our issues are, and, you know, if things are changing in an unhelpful manner, then obviously we would seek support.
Thank you, Tony. Simon, you wanted to come in there.
I would. Thank you very much indeed. Apologies, my throat's a bit croaky today, so hopefully it'll hold out for a little bit longer. Thank you for the question. I would very much ask you, as you have always done, to continue to amplify our messages around important services. So things like our waste medication campaign, for instance, that costs pharmacy, community pharmacy and health services an awful lot of money, and we've been over the last year putting out lots of messages around the importance of ordering what you need, and also about the ways you can dispose any unwanted or unneeded medication in a safe way. But we've been very active and proactively pushing out messages around the medication, how you can be really clear with your pharmacist around what you need and only order what you need through your GP. So I'd definitely ask if you can help with that. And also we've done quite a bit of work around Pharmacy First as well. Pharmacy First has been part of our winter and also our summer campaigns as well. So this is where pharmacists can help with answering a number of different common questions around keeping yourself well and advice. So helping us to promote that within the local communities that you serve would really, really help us too. We did run a campaign a couple of years ago around no excuse for abuse. So this is where some of our primary care and also some of our community pharmacists have experienced abuse within the workplace, and we're looking to possibly do something in the near future about that to increase awareness around that type of behaviour not being tolerated within those settings. So I think anything that you can do to help us amplify messages within the local community would be really helpful. Thank you.
Thank you, Simon.
Can I come back again?
Yeah.
Forgive me. I mean, I'd like to touch on the area of two things. First of all, the medication and the shortage of medication is a national issue. The medicine supply chain in this country is somewhere between fragile and broken, and that is multifactorial. Individual items might be manufacturing problems or distribution problems and things like that, but I think many people will be aware that we pay in this country for medicines a lower amount than just about anywhere else in the world. And that means that actually if you're a manufacturer or a wholesaler, it doesn't pay to sell your medicines in this country. So you keep a just-in-time stock for England and you sell your medicines at far greater profit to other parts of the world. And that underlying is the source of the issue. So that's the medication issue. The abuse issue is increasing. In fact, there's a national survey of pharmacies going on at the moment about levels of abuse. And of course, as councillors, I'm sure you do get patients contacting you about your community pharmacy services and things like that. Quite often, the abuse that comes to community pharmacy, you know, I'm not saying our guys are perfect, and of course they make mistakes and things go wrong, and you know, we would always apologise for that and do our best to put things right. But we're the end of the line on a prescription journey or a healthcare journey. So if something's gone wrong down that line, then it is the community pharmacy staff that get the blame for it. And there's even some really, really bad examples of this, like the COVID vaccination this year for winter. It was not really well publicised, but the government cut the eligibility from over 65s to over 75s and so special health conditions without really telling the population that that's what had happened. So people went onto our national booking service and booked, tens of thousands of people booked on to have their jab in a pharmacy, and the national booking service allowed them to do that. And there was nothing on there to say, you know, the eligibility's changed. So for several weeks, and in the best part of a month, our pharmacies had people coming that then they had to tell, I'm sorry, you're not eligible. And that resulted in a huge amount of hostility. From this patch, things like, I'm going to sue you if I get COVID. Nationally, pharmacies have been spat at and other things because of a breakdown in national messaging that, and actually it affected our pharmacies financially as well, because we all booked slots for those vaccinations that then went unfunded because the patients weren't eligible. So that's an example of actually just, you know, national failings in thought and communication having a real mental health impact and financial impact on our pharmacies. So, I mean, I guess in answer to your question, sorry, Councillor, is it Robinson? Yes, thank you. That's what I only said the first bit. Yeah, I mean, if you have contact with your patients, you know, we would, in the past, we've worked with Health Watch, etc., to, you know, the Be Kind to Pharmacies message, and actually to help us contextualise, not excuse poor service or anything else, but contextualise just the massive pressures our pharmacies are under, and help us ensure that, you know, nobody thinks that that allows them to then be physically and verbally abusive to pharmacy staff, because it's actually becoming a sector that some people don't want to work in because of that, and I'm worried about that.
Thank you, Tony.
Thank you, Chair.
Councillor Shaw.
Thank you, Chair. I'm really pleased, Simon, that you've, and both of you have just raised the whole issue of hostility and very aggressive and unpleasant behaviour towards staff at pharmacies. I'm a member of a patient participation group, and this is something that comes up a lot with the GP surgery, and I heard a recent comment from them that because people turn up to our A&E, it's well guarded, the risk there is minimised because they have security guards. If there's someone hostile, it's much less of a dangerous situation. But people in the front line, and yourselves and GP surgeries, really feel, I think, and from what you're saying, that underlines it, that you're very much on the front line, you're almost the first base, easy target. And I'm just wondering, it's something that's been playing through my mind as you've been describing this, whether your staff have particular training in dealing with these sort of hostile situations. People really do not understand how the system works. I often hear that from residents who contact me, knowing that I'm linked with the PPG, and I know everything, you know, because I have that link. And these assumptions are made, and I think there is a sort of gap in information there where people don't realise what the service is about. And I just do wonder about the levels of support and training all the staff have in pharmacies now. Is there something, a dedicated training programme or something to deal with hostility and so on?
I think the honest answer is we're getting there. It's been a fairly rapid increase in hostility, frankly, and that has just been, our guys have been so resilient, but the funding cuts are now biting that it is affecting service. And you know, for many people we would admit that, and I think there's some statistics in the paper that admit that. So it's a relatively new thing. I think historically some of our pharmacies have had you know, the customer is always right. I think it's a retail environment, not a patient environment, and have felt nervous about tackling and standing up to that behaviour, although it's been a zero tolerance in the NHS. It's only now, I think, we're feel as though we're part of the NHS rather than a separate body. So I think we're getting there. We're doing a lot of work, our national body's doing a lot of work, and indeed our ICB always helps us where these situations arise. Ultimately, of course, it is the responsibility of the employer to take duty of care for their staff, and we are, you know, working hard with our contractors to make sure that they do understand that, and they do understand that they can ban people from the premises and refuse NHS service full stop. And actually, until about 2 or 3 years ago, there's a wide-held myth in my profession that you couldn't refuse. You could ban somebody from the premises, but if they brought the prescription to the door, you had to see them at the door and offer them service. So you were still interacting with that patient, whereas actually there are clauses in our terms of service where things get extreme that say, no, of course, you, just like any other part of the NHS, you can refuse service. But that is still probably not well known. But again, we need to be balanced about this, because we do need, you know, patients by definition are stressed, they're unwell. You know, we have to take certain amounts into account, but obviously, and if somebody gets banned from all the pharmacies in a town, then where do they get their services? So that becomes a problem, I think, largely for the ICB, but it's something that, because we're partner working in, we want to come to solutions. Sometimes you can have sort of written agreements with the patient that it's a last chance, etc., and you can carry on things like that. But I think the extremes are probably easier to deal with than just that increasing low level of nastiness, if you see what I mean. And I do need to put it into context. The vast majority of our patients are lovely, wonderful people who get on really well with the pharmacy staff. They've known them for years, and they have almost a familial relationship with them because they've seen their kids grow up and everything else. So I don't want to over-stress the problem, but where something is clearly, we feel, on the rise, then the faster you nip it in the bud, the better.
Thank you, Tony. Councillor Lockington.
Thank you, Chair. Yes, one group of pharmacists which you haven't touched upon is actually the hospital pharmacy, because hospitals also have pharmacists. And it's often a good place for doctors who are often the people who may start a patient on a medicine, because they can then liaise with the hospital pharmacy and try and learn about if certain medicines are more available than others, because that if there is a choice between different medicines that more or less do the same, you can then try and choose. But I think I'd like to know how you liaise with the hospital pharmacists. And then I have another sort of question. I better declare I'm the Vice President of the local UK, Parkinson's UK local branch. And I'm well aware that your report talk about that there are certain pharmacies that can have a stock, I think, of end-of-life medicines to be sure that they are not. But there are also all our residents who have got long-term conditions like Parkinson's. It is actually extremely important that their medicines are available. And I have heard that sometimes there are shortage, so people can't get whatever medicines they need to be on. So we need to be sure that all medicines for people on long-term conditions also are allowed to be held extra, because, if you can't get your medicines with Parkinson, you can end up freezing, as it's called. So it is important that you get your medicine. So that were my two questions to you for now.
I don't know whether.
So as an ICB, we liaise very closely with the trusts in our area. So West Suffolk Hospital, I'm talking from a SNE ICB perspective, West Suffolk Hospital and ESNEF, so both the Ipswich and the Colchester sites, we have interface pharmacists. So we have pharmacists that are partly employed by the ICB, partly employed by the trust. And that's really helped enable a smooth interface across, not just from hospital pharmacy to community pharmacy, but with general practice and wider partners. So those roles are really beneficial. We have an integrated medicines optimisation committee, so again that's supported by all system partners for the discussion of medicines commissioning, formulary development and the likes. And then there'll be various other things. So for example, the integration project that both ICBs commissioned was looking at one of its key priorities. It was four priority areas. One was the discharge medicine service, and it's trying to improve that discharge from hospital where there may have been a change to someone's medicines, to ensure that that's communicated effectively back out in primary care, that everybody understands what the change has been, including the patient, what needs to change, what needs to be supported, and what advice can be there, so that we try to minimise those dangers across those transitions of care. There are challenges with that, but actually by using the projects to try and highlight the opportunities there, we are doing everything we can to try to raise awareness of that opportunity of increasing that communication. So there are certain levers that would mean that we're in constant contact with the hospital to some extent. With regard to the medication, prior to joining the ICB, I've been a community pharmacist for 20 years, and it's heartbreaking to hear when you can't access a medicine, and it's honestly heartbreaking to be the person that then can't fulfill that person's prescription when you might have been doing it for several years. As Tony mentioned, there are challenges to the supply chain, and they're very unpredictable, and you won't necessarily know which long-term condition or short-term condition that might be affected next, and then there will be potentially a domino effect. Some of them will be resolved relatively quickly and some of them not being. And so the challenge would be which medicines to include in a kind of specialist medicines or urgent access to medicine service. So for now, we've tried to focus on those needed for palliative or particularly end-of-life care, along with some very time-critical medicines such as treatment for some severe infections that can be managed in the community, and that now would include COVID-19 treatment. So, but absolutely, the list of medicines and for the conditions for which we consider that service, they're never locked, they're under constant review, and again, based on demand and maybe what is happening in terms of local commissioning of services, that list of medicines could be flexible. But I have no magic answer for you about the Parkinson's medicines, unfortunately.
Thank you very much indeed. Councillor McLaren.
Thank you, Chair. I have a very rural ward, and within that, and a sort of a wider area than just my ward, there is a dispensing GP practice. But I'm interested in the schools work that you did in terms of flu clinics and COVID. Is that an established practice that you can go into schools? Because I'd like to know what the process is, because I would like to encourage it. I've got to say the schools I've got a private school, an academy and 2 primary schools, but actually many of the students are not local, so they will not be related to the local GP practice. How do we encourage that to happen? And could you explain the process to me? Thank you.
I can certainly try. The school vaccination programme is separate to delivery from community pharmacy, and actually would be commissioned through a local provider. So all of those schools for children who would be eligible for the vaccine would be visited on a kind of planned basis. Sometimes once, sometimes more than once, depending on the size of the school. I mean, I'm sure there's a rationale behind who gets vaccinated first and who doesn't. But effectively, from the beginning of the campaign all the way through to ordinarily the end of the year, as opposed to the end of the flu season, an external clinic will come to visit the school and vaccinate those children. I think for early years this year, this was the first year where we had some national commissioning of intranasal flu for particularly young children. That's not been a thing that's been a possibility for community pharmacy before, but for example, the nursery or preschool setting, that cohort could have been vaccinated now through community pharmacy with the intranasal vaccine, which hadn't been there previously. So that's a really encouraging sign in terms of improving access to that cohort, because a preschool or nursery won't necessarily get visited by the school vaccination nursing team, but primary school, secondary school would do. Does that help answer the question to some extent?
Yeah, I'm just trying to get, because I don't remember hearing about any. I must pursue it actually. I was thinking about my own schools. What about a boarding school? I've got a very big boarding school.
I'm going to confess that I'm not the vaccination lead for the pharmacy, but very happy to take that away as a question. I work very closely with our vaccination lead.
Yesterday, and I want to encourage as much as I can. I mean, in the old day, when I was around the health service, I mean, there was school nurses that were based in schools, but I'd like to pursue that. Could you get back to me on that?
My understanding is covered illicit private sector, which might be slightly different.
The children are still entitled because they're within the age range specified to receive the vaccination. So it probably doesn't get as much attention because it's one of those things that just happens. It's commissioned regionally, it's delivered regionally. I think I'm right in saying that Hertfordshire Community Partnership deliver it for Suffolk. We in the public health team worked very closely with them during COVID to say, actually, where do you go next? Because we could see where all the infections were, so we worked really closely with them during the pandemic to say, go here, go here, go here. But as Lee says, in kind of normal times, they will have a programme that will cover the school settings of every age of child who is eligible under the national programmes. But we can come back to you on that.
Thank you very much for that. Drifting a bit out of community pharmacies, so if we could stick to the subject. Councillor Robinson, you want to come back?
Thank you. It was only a quick one following on from my earlier question and about the time management problems with the lack of messaging on the COVID vaccinations. Is there a role for public health in this, in the messaging side, or is that all done from NHS Central?
It is largely done from NHS Central. We don't have a role in influencing the cohorts. That's decided by things like the Joint Vaccine Committee and things like that. We certainly do try and publicise it, working with Simon and jointly to get the messages out about please go and get it. We know that flu, for example, came early this year, so it was really important that people had sort of gone out and participated in the flu vaccination programme. I would say in Suffolk, particularly amongst older people, we get really pretty good flu vaccination take-up rates, but we watch that, and we watch it for other groups as well who can be at risk of flu, and a bit like Tony was saying earlier, there's always room for improvement, but we work together on trying to get those messages out to the right people. Simon, I don't know if you want to build on that.
Yeah, I would. Thank you very much, Anna. So we have a vaccination service website called snevaccine.org.uk. It's been live for the last few years. We introduced it during the height of the pandemic, during the rollout of the vaccination. And it really does list all of the walk-in centres and walk-in services for flu, for COVID, for RSV. And on that website also, I'm sure you're aware of it, we have promoted it far and wide, especially during the pandemic. But on that website, we've also got infographics which pictorially describe who is eligible, what are the age ranges, where you can get the vaccination from, and where to go for more information as well. So we do put those out on social media and on our various other platforms as well. But please let me know if you want more information about that, and I'll happily send that to you.
I was just going to say that the message on the latest COVID ones, the message about who was eligible didn't really reach the public. That was everybody who'd previously had a COVID vaccination thought they were entitled. I mean, that was only, I didn't directly know that I wasn't entitled anymore, because people didn't know about this site that you're on about. I mean, I read it in the paper, so no problem. But yeah, it's getting that message out to people. They think, oh, a COVID vaccination, I've got to go. We didn't get the message out about who shouldn't go.
Thank you. Councillor Rowe.
Couple of questions. One is, do pharmacies take part in like shop safe type schemes? Because I know in Stowmarket, for example, we're looking at developing one there, so it'd be useful to know, to kind of be able to check that they're included if that sort of thing they'd want to be. And also, with changes to NHS England and the postponement of the mayoral elections, is there any kind of bit which is not going to be covered because basically there's a bit of a gap of between those, I think with some of those, like with those two, where it thought there was going to be a join up with some like strategic health stuff, and then there's now a gap of a few years, and I'm not sure we entirely know what's going to fill that gap.
Everyone's looking at me. As I understand, can you deal with the shop safe point, Tony? Thank you. As I understand it, and I'm not the lead on this, but the mayor, should we go there, will have a duty with regards to improve the health of their population and to reduce inequalities in health. So they have a duty to deliver on that, but that's not the same as saying that services will move. It's not the same as saying that they will be delivering any of that. So I think the way certainly that I've been thinking about the role of the mayor is in what the mayor does do. So perhaps economy work or skills work, they have a duty to consider health and well-being as part of that, which will amplify what we're doing, which is, you know, potentially very positive. So I don't think there's a risk of a gap. I can't speak for NHS England. You might be closer to that than I am, Lee. But in terms of who commissions, who provides, who pays, that is not changed by the function of the mayor as I understand it. It's possible that the mayor will be able to amplify some of those messages. Things like workplace health are very important. Vaccinations can be part of that, etc., etc. But you're right, we do have a little bit of a time to wait now before that gets itself up and running. So, but I personally don't think there's a risk of a gap in the meantime. Do you agree with that, Lee? Yeah. Okay.
And in terms of the stay safe and local arrangements with, you know, in between different retail outlets and things like that, yeah, I'm pretty sure that, I mean, I don't have stats for you, I'm afraid, but I do know that most of our pharmacies do engage very, very closely with those where they're available. We do sometimes, of course, have pharmacies open beyond the hours that arrangement operates. If, you know, the rest of the retail shuts down at 5:30 and the pharmacy's open until 9 o'clock, then it's rare that those security people are employed just because one business is open. And we have had a very recent incident in the last couple of days up in Great Yarmouth where there was great hostility in a pharmacy. It took the police half an hour to arrive, and of course that does cause significant issues. But I think where the opportunities are there, absolutely, and by all means, if there's something available, I would encourage them to reach out to their pharmacies, because believe me, they will be very keen to all help you can get in these situations. Absolutely.
Councillor Lockington, you wanted to come back?
Yes, another question from me. And I suppose it's to Tony, to take back to your pharmacies. If a patient have an arrangement with a pharmacy that they book the repeat prescriptions, and the patient hear nothing after a while, thinking, I better get down and see what's happening. Now the pharmacists say, well, I ordered your prescription well over a couple of weeks ago, but we haven't got it. So you ask the pharmacy, but what happened when you order a prescription, nothing comes back? Is there not anything on your computer system that after a week or after some days flag up that you haven't got it? No, we don't. They just let it go. And I think that, nowadays with computer systems, there ought to be something that if you've ordered a prescription from a GP and hasn't come back, they ought to come up on your system, at least after a week or after a few days, to say the prescription hasn't come back. You maybe need to look at whether you had ordered it properly or not, or something. Can that be done?
If this had been a year ago, I'd have said no. And the answer has already been mentioned this morning in another section. It's the NHS app. Actually, now you can order your prescriptions on the NHS app and monitor exactly where it is in the process, right up to it being ready for you on the pharmacy shelf. So that is a function that is already available for patients. Now, of course, the challenge is upskilling patients and helping them to use the NHS app and using that technology. And of course, our pharmacies do their best to try and do that. But and some pharmacies will text a patient when it's ready, etc. But ultimately, we don't know something. If a patient's ordered it directly with the surgery or via the NHS app, we don't know it's been ordered until somebody says, where is it, if you see what I mean. So, and actually allowing us to access your NHS app to be able to have a look at where it is in the process, or asking you to do so for us, actually does help us see where it is along that journey, if that helps at all.
I understand what you're saying, but during COVID and so on, we were all encouraged to book up with a pharmacy who would then do things for you. So it's not about the patient with their own app, but it's about if you put your trust in a pharmacy who says, well, we'll do things for you, then it would be nice that, for patients, that if it worked.
Yeah, some pharmacies do still offer, and it is a decreasing amount because it is extra work that unfortunately is unfunded. And this is one of the things that some pharmacies have had to do to cut back on things that they're not funded for, is what's called a manage repeat, where the pharmacy will take your order and actually put the order in for you. Now, where the pharmacist put the order in for you, then it will chase it up if it doesn't come back because you know it's been ordered. But there is no current way of a pharmacy knowing that something has been ordered. Of course, if somebody contacts their pharmacy and said, they will help chase it up. But there is no automatic, flag that says this patient's ordered a prescription. Because apart from else, different surgeries take different amounts of time to produce that prescription. It can be anything from half a day to 3 or 4 days up to a week where there are particular problems, etc. And then obviously, just because the pharmacy's got it doesn't mean it's ready, because that then needs to be the stock ordered and assembled, etc. So exactly where it is on that process will depend on the information that the pharmacy's got, and frankly the capacity also to deal with. I would like to think our pharmacies are very, very good at trying to look after as best we can our particularly vulnerable patients. And many do still go way beyond what we are contracted to do to help our vulnerable patients. But we're under huge pressures, and as I say, unfortunately, people have to start looking at the contract. If you're not going to go out of business in 6 months' time, you have to start looking at the contract. And our guys will always bend over backwards. And I think the fact the general public hasn't really noticed, to a lot of extent, the huge angst and pressures on our pharmacies is probably tantamount to the swan effect, that they're still gliding along the surface with their legs pedaling like that under the water. But unfortunately, some things suffer when you are under huge pressure, and the ability to go that extra mile all the time consistently is under pressure, and I'll just be honest about that.
I think everybody can identify with what you're saying there in terms of the experience, and I think one of the really encouraging things in the NHS 10-year plan, as Tony says, is the promotion of the NHS app as the digital front door of the NHS app. We've seen over relatively short periods of time huge increases in the amount of functionality that exists, and absolutely that's the right way forward. We also recently participated in a digital upskilling project with our Integrated Care Academy. The evaluation is not yet finalised, but effectively about 2,000 people were reached through our community pharmacies, nearly half of whom have then engaged with the NHS app that hadn't previously, or had signed up to it previously, maybe for COVID pass, but not for some of its other functionality, like booking appointments, ordering prescriptions, and as Sony says, the tracking, it's ordered, it's now been prescribed, it's now been sent to the pharmacy, in fact it's now ready for collection. That kind of process that, I don't want to use the term, but it is Amazon style all the way through end to end, will be really, really valuable to everybody, I think. And I think the other thing that was part of the project, which when we were in its creation stage, is trying to look at how do we support people in areas perhaps of digital poverty, and actually is it things like patient participation groups that could facilitate with patients the access. And it's, being as you've raised the question, I'll share a personal example. I order medication for my parents. They live quite far away from me, and they trust me because I'm a pharmacist, so I should reasonably do that. Went recently to order a prescription for them through a pharmacy that then gets it delivered to their house. One of the prescription items never got prescribed, didn't get scheduled for delivery. I wouldn't expect the pharmacy to chase it up, and the only reason I end up finding out through logging into my father's records was that actually he'd had a review recently at his GP practice, and the person who'd then done the review decided to generate a prescription, sent it randomly to a totally different pharmacy for some reason. I'm not entirely sure why all that happened, but we were able to track it down. But there, where you've got the pharmacy potentially placing the order, they wouldn't know that any of that has gone on, and quite rightly shouldn't be shared, some of that information. So the whole principle of expanding the NHS app, making it more easier for people to use, but having the governance controls so that they can appropriately use it, I think for us has definitely got to be the way forward.
That's really interesting. Now I think our final speaker, Councillor Thompson.
I know from, because I'm signed up to health groups on the internet, and I know that there is a disease in the US which has killed 8,000 people. So what latency would you think if, because I understand that the government's destroyed our ability to produce vaccines at the end of the pandemic. What latency would you think we would have if they tried to ignite that ability and get it to the pharmacies anyway?
So that's quite a complicated question. I would say that it's part of the medicine supply chain issues which Tony was talking about earlier. Vaccines are increasingly made globally, so they might be innovated as the COVID vaccine initially was. The AstraZeneca one was innovated in Oxford, created in Oxford, but it ended up being manufactured in many places around the world at actually a really extraordinarily short amount of time, really, when you think about it. But there's lots of processes within there. There's regulation, there's testing, there's safety, there's all of that. And my personal answer would be that's a global issue. We have some manufacturing capacity in the UK, and colleagues will probably know more about it than I do. But it depends what sort of vaccine you are manufacturing, under what conditions, for what disease, really. And I wouldn't like to pretend that I know whether we have the capacity to do all of that in the UK or not. Though we certainly have the capacity to innovate and create vaccines, and if anyone's interested, the book written by the people who invented the AstraZeneca vaccine is a genuinely fascinating read. But the production of vaccines, and it needs to be global, because if you think about the number of people all around the world who need a vaccine against a pandemic, that global resilience is really important. I'm probably slightly waffling, but I do think we can innovate in this country, we can develop, we can test, we can ensure safety, but the actual manufacturing and those sort of lead times, I think, are a more complex international issue. I hope that makes some sense. Do you want to add anything to that? No? Okay. Thank you, Councillor Thompson.
Thank you, panel, very much indeed for your input. And now we're going to come to that part where we look to make some recommendations. We did think that it might be helpful if the committee asked myself and the Vice Chairman, Inga Lockington, to draft a letter to the Minister emphasising the points that you rose, Lee, at the top of page 34 of the papers, which Community Pharmacy England summarised. There were 4 major points, and we can elaborate on those rather than just copy them out, because that wouldn't seem correct. And perhaps add to that, I don't know what the councillors think, digital poverty to be taken into account when introducing the NHS app. And it's not just about urban pharmacies, it's about rural pharmacies, and to perhaps emphasise that as well. Then you've got the communication about medical waste and disposal, the vaccination programme, reducing abuse of frontline staff, and actually how we might all think we know everything, how we actually use this app. But I think, please, say if you think that's sufficient recommendations, or you would like to add something else, and are we over-egging it? Panel members, do you think that covers everything we've talked about today? We love our recommendations.
Okay, I admit it is a difficult one to make recommendations because so little of it is down to Suffolk County Council. I think we should support them in their efforts in dealing with the government over the funding, etc., etc. I don't think we can do a huge amount more. We can just reinforce their points.
We'd all like to do that because community pharmacies are important to all of us. And you're being asked to do so much more as well by the government, aren't you? And although they've put the funding in for that, they haven't looked to see how funding has been lacking in just normal procedures. Simon, you wanted to come in?
I did, thank you very much indeed. I mentioned earlier, if you could help us amplify our messages to your communities, that would be really helpful. We are supporting a national campaign around the NHS app at the moment, which is very much encouraging people to switch on their notifications on the app and also to be aware of what the app is there to do. So one of the things that Lee mentioned earlier was around ordering repeat prescriptions. So we'll get some messaging over to you. We're in the process of really sort of ramping up our comms around that, so we'll share that with you. But anything you can do to help spread that word would be really appreciated. Thank you.
Thank you. And we'll draft the recommendations and send them to you so that you can add or delete whatever. So thank you again very much indeed for coming. And I'm sorry we kept you waiting at the beginning, and hopefully we'll see you soon. So we come to item 7, which are reports from board observers. Has anyone got anything they would like to report? Yes, Councillor McLaren.
Chair, I sent round last night a report that was from my visit yesterday to the Future Systems Board in West Suffolk Hospital. The meeting, as I said in my email, has a lot of confidential information, and so the report I sent to you was sent out by their comms lead, so that whatever goes out into the public domain in West Suffolk, that is what I sent yesterday.
And I apologise because I haven't had time to go through it in any detail. I haven't had time to go through it in any detail.
No, it's huge. I mean, it's huge.
Yes. But
and of course, we've got Gary coming next week. We've got an online meeting with Gary Norgate, who's the director of the programme.
Thank you for sending that. It's very helpful.
Thank you.
And was there anything that anybody wanted to bring up from that? And then I've got an extra item which we can deal on the forward working programme, which is being raised by our colleague Councillor Mason. So Councillor, can I ask you if you would just go through your concerns about the ambulance service?
Thank you, Chair. I'm asking today that the ambulance response times in Haverhill and other large urban communities remote from hospitals are added to the Health Scrutiny Forward Work Programme. I do so as a local county councillor in Haverhill, but also on behalf of Haverhill Town Council, of which 2 members, Councillor Tony Brown and Councillor Alan Stinchcombe, have raised persistent and ongoing concerns about ambulance response times in Haverhill. I know this is not a parochial concern and is not an isolated anomaly. It's a structural issue about equity of access to emergency care across Suffolk and about whether our current arrangements distribute risk equitably across communities or merely optimise system efficiency at the expense of those furthest from hospitals. The evidence provided by East shows that Haverhill's Category 1 response times are consistently and materially worse than those in areas close to major hospitals, particularly Cambridge. Over several years, Haverhill's mean C1 response time has exceeded Cambridge's by between 5 and 8 minutes, and the 90th percentile by 12 to 14 minutes. These are not marginal differences. They represent a sustained and predictable gap in access to the fastest emergency care. Initial care in Haverhill is now almost entirely reliant on the highly valued community first responders, but delays in ambulance response and onward transfer to hospital can have serious negative impacts on patient outcomes. There's been some recent modest recent improvements. Haverhill's average Category 1 ambulance response time is down from around 14 minutes the previous year, but still averaging 12 minutes in 2025. It is important to be clear that improvement does not mean adequacy. A 12-minute average response time for the most life-threatening incidents remains far above national expectations and far outside what is experienced in urban areas served by the same trust. The ambulance service places strong emphasis on hospital handover delays and wider system pressure. Those pressures are real and well understood. However, they do not explain why the burden of delay falls disproportionately on communities like Haverhill. What we are seeing is the outcome of deployment decisions taken under constraint. When ambulances are allowed to remain concentrated around hospitals to protect trust-wide averages, response times in remote towns deteriorate as a matter of design, not choice. Haverhill Ambulance Station now largely functions as a garage rather than a standby point. Removal of a tethered rapid response vehicle coincides directly with the deterioration in local performance. That link is visible in the data. The argument that tethering resources is unethical because it increases risk elsewhere overlooks the reality that not tethering concentrates risk here. There's also a significant analytical gap. Response times are assessed in isolation from onward transfer to hospital. Despite Haverhill having a marginally longer journey to A&E, for residents in remote communities, the total delay from call to definitive care is substantially longer than headline response figures imply. I believe the committee has a role in testing whether the commissioning and operational arrangements deliver equitable outcomes for residents, regardless of geography. Adding this issue to the forward work programme would allow sustained scrutiny of response time inequality across Suffolk. The incentives created by current targets and system status planning, and the levers available to the Integrated Care Board and this authority to require corrective action. That includes transparent local level reporting, clear expectations around acceptable disparity, and meaningful mitigation for communities remote from hospitals. I understand that delays to hospital admissions, discharging of patients, freeing up of beds and prompt release of ambulance crews are contributing factors, but these should not distract from East's mission to significantly reduce the discrepancy faced by large communities like Haverhill. This is about fairness, patient safety and accountability. Without structured and sustained scrutiny, this issue will continue to be managed rather than resolved. I'm therefore asking the committee to take this work forward formally. Thank you.
Thank you very much, Councillor Mason. I think we forget that Haverhill has grown in size over the last few years. You've got 2 large housing estates nearly completed now to add to the population, which I believe is about 40,000.
Thank you, Chair. We're currently around 30,000, but the growth predicted in the years ahead will take us close to 40. Thank you.
Councillor Robinson, you wish to speak?
Thank you. I agree that ambulance waiting times are a concern. They're a concern all over Suffolk, particularly in North Suffolk. Handover times are getting ridiculous in North Suffolk. You go to the James Paget Hospital, which serves a third of the county of Suffolk, and the queues of ambulances outside, you wouldn't believe. And those ambulances can't be in Haverhill or any other out-of-town area waiting for a patient. They're still queuing up at the hospital. So I think it's something that's worth looking at. I think we should widen scope to Suffolk rather than just Haverhill.
I was going to suggest that actually, councillors, that perhaps we hold what we call a workshop rather than task and finish, and we can ask the ambulance service to send representation, and we can have the chance to speak, and Councillor Mason would be welcome, perhaps with the resident that felt so aggrieved with having to wait. Councillor Lockington, you wish to come in?
Yes, I think that would be the best way forward. And apart from the ambulance service, we may need also to have somebody from like an acute hospital or something, because in case the ambulance service bring up some issues, you know, we need to be sure that we can actually deal with that on the same day and ask the others, you know. So, yeah.
Thank you, Chair. The only thing that I would want to emphasise, and on behalf of Haverhill Town Council, as you've often heard from other councillors, Haverhill is the 4th largest town in Suffolk. We don't have a hospital, and we have a large population that serves a large rural area. And I think one of the bones of contention is that by not having an ambulance return to the area, it's not just Haverhill, which is a large population, it's a significant rural area around Haverhill that also is badly affected. I entirely agree, it probably isn't solely an issue for Haverhill, but the size of Haverhill, I think, emphasises the concern that I would like to make. Thank you.
We will make sure that comes through. So is everyone happy with that proposal? And the work programme? Oh yes, I'm sorry, I meant to say you all got that briefing note. Thank you. Now the work programme, I feel a little concerned because none of us know what's going to happen over the next few months. We should hear in February whether we go ahead with our elections or we don't. And so it's difficult to sort of plan for the future, but we're meeting again in March. So, and we're doing the elective surgery at Ipswich and Colchester, and we hope the interim CEO will perhaps come along and speak to us, and maybe the interim chairman, which will be interesting. So I think there's quite a lot we want to put on the work programme, but at the moment I think perhaps we should wait until we know what our future is before we plan, and perhaps if we did have elections and there's a new administration, they might not be very happy with our ideas, but what do you all think? Do you think we have our next meeting and then we go from there and we'll know more by then and then we can plan the future programme? Thank you, I'm glad you all agree, and thank you all. Inga, yes.
We have mentioning of the teenage pregnancy.
Yes, but I saw
when we
that.
had the item number, was it 7? At the very end of that, it says an update on the graphs and charts as set out in a written report for future meeting to demonstrate how the services were progressing will be provided in July. And when I read that, if that is July to come, it would be, we shouldn't be looking at that in March because we might as well wait and see more information.
We'll take that one off and we'll deal with the elected.
I think it could be on because, you know,
yes.
A new group of councillors, if there's a new group, they may want some ideas to
yes.
go forward with.
Yes. Thank you, and thank you all very much indeed for coming. If you could make sure you take all your papers and your cups and glasses with you, I'd be very grateful. And we're closing the meeting at 12:42 in time for lunch. Safe journey home.